Okay, antiemetics, quick set of slides. So, of course, you can have nausea and vomiting from a lot of different sources. This kind of applies to the whole talking about bowel meds in general. A lot of these things can happen for a number of different causes. And really, you're looking at some sort of a natural reflex of the body to get rid of toxins or poisons that have been ingested. So anything from post-anesthesia to some sort of an acute bacterial illness, they can all cause nausea. You have a different number of approaches you can take, and a lot of the stuff is going to be similar to what we've talked about. So dehydration status and electrolyte imbalances, still important to consider. There's a couple different options we have, and there's a group of receptors that are all thought to play some sort of a role in nausea and vomiting, and you have a few different things to talk about here. So there's a couple ways we can look at treating nausea and vomiting, but really all it's doing is working in a similar chemoreceptor zone within the brain, and that's shown to affect the way our body processes information that relates to throwing up or vomiting and that reflex, and what makes us feel nauseous during those processes. And a lot of it has to do with interacting with these specific receptors in the central nervous system, in a specific part of the central nervous system. So when we're targeting them, we're going to talk about dopamine receptor medications and medications that target histamine and muscarinic receptors. And a lot of that has to do with specific areas. So sometimes we're talking about broad medications that have lots of other effects too, but they happen to hit some of these. So for example, Benadryl or diphenhydramine, not thought of as an antiemetic, but actually does have some antiemetic potential because it touches on some of those muscarinic receptors in the central nervous system that relate to the nausea and vomiting reflex. So anyway, we'll talk about these a little bit more. There is a neurokinin-1 substance P receptor medication called aprepitant, which is chemotherapy use only, so I'm not going to go into a ton of detail on that. But when you're looking at nausea and vomiting, I don't think there's a lot of good evidence out there that says we're good at controlling this. There's a lot of drugs that get used a ton, and so I think people rely on anecdotal experience or what's working for a patient. Unfortunately, a lot of them are relatively safe to use, so there's not a lot of side effects to talk about. And there's not really studies that compare the agents or classes. We'll talk about a little bit of the literature that's out there, but as far as good head-to-head studies with large groups of patient populations, it just doesn't exist. A lot of these drugs have been around for a while, so no one's really jumping out of their chairs to study them. Okay, let's start with probably the most mild antiemetics, anticholinergics. They don't really have a huge role in acute treatment of nausea, and especially scopolamine doesn't really have any role in acute nausea. Sometimes you'll see scopolamine patches used during surgeries, though. So sometimes they might have some kind of a role, but that could be for the anticholinergic effects as well. The purpose of these drugs is, the scopolamine patch, is to prevent motion sickness. So you start it a couple hours before you need to. So before you get on your cruise ship or get into a long bus ride or wherever you get nauseous, you're going to put the patch, and it goes directly behind the ear here. Side effects are anticholinergic, so dry mouth, drowsiness, and vision disturbances. It tends to be the anticholinergic effects you'd expect from the neck up. Don't really seem to get a lot of GI absorption or disturbances. And the idea is you're absorbing it. It's probably getting somewhat into the systemic circulation, but the thought is maybe it's near the brain, so it gets to the site of action faster. I don't know if I totally buy that. But the reported side effects with GI-related or urinary retention or any of those common anticholinergic effects we associate with, not going to be really seen with this for the most part. It's not reported in high amounts. But vision disturbance and drowsiness, dry mouth, certainly. Older people tend to be more susceptible to this medication specifically too. And I've seen people who have actually gotten toxic using them normally, so some elderly adults who developed anticholinergic toxicity using them. So just be careful with them. But for the average patient going on a cruise, that's no problem whatsoever. Although I question why you're going on a cruise if you get motion sickness for being on a boat. But that's another topic and discussion that we don't need to have today. Other antihistamines, diphenhydramine or Benadryl. Again, I talked about this already, but it's going to have much stronger anticholinergic effects than the scopolamine patch, and so it's going to be a more potent medication to use. It is okay in pregnancies, so if you do work with that patient population at some point in your career, it's one to keep in the back of your mind. It's effective potentially as an antiemetic in pregnancy, and that's a common complaint for pregnant women, right, is nausea. So if we can give something that helps with that, this could be a good advantage for us that it's okay in pregnant patients. Promethazine with codeine, plus or minus. So promethazine with codeine was this half-baked attempt at a cough syrup that has some sort of a sedative added to it, and it basically ended up getting abused by lots of hip-hop artists. I can't remember who that was. It's some Instagram post. Anyway, the company that made this product doesn't make it anymore because it was basically widely getting abused and no one was taking it for any type of therapeutic benefit. But promethazine by itself is actually a useful antihistamine / anti-emetic, and it's one that's made a bit of a comeback. Methergin is the name, or not, sorry, not Methergin. Methergin is a different drug. Blanking on the brand name of promethazine. It'll come to me. But anyway, promethazine's one that's kind of made a comeback. It wasn't useful that often. And then we ran into a bunch of shortages with some of our more preferred antiemetic drugs, and so we started bringing promethazine back. Now promethazine actually has some effects. It's got weak dopamine activity, and it's going to line up with some of these other drugs we're going to talk about. But it's also an antihistamine, too, so it's kind of a hybrid. So, yes?
Is it repulsive?
No. Shoot. Gosh, right on the tip of my tongue. Don't come to me. It might be different oral or IV. There might be different names for it.
Drowning?
Huh?
Drowning?
It's not drowning. No. So,
I don't know.
that's okay. I'm just thinking, like, what is it? Okay, so anyway, dopamine receptor antagonists. So these drugs are blocking dopamine receptors. So again, promethazine does have some dopamine receptor blocking potential here. So it's kind of a hybrid between diphenhydramine and prochlorperazine, but it's a bit weak on both sides. So if you really want a stronger drug, one of these is probably going to be better. So prochlorperazine is compazine, and compazine is probably one of the most popular antiemetics out there. It's thought to work quite well, although the data, if you actually look at the literature, is really limited. We don't really have a good clinical rationale for that this drug is very much more effective than anything else we use. But if you work in hospital medicine, you're going to see compazine pull up on pretty much every post-op order set. Any order set that involves nausea and vomiting prevention, it's going to have prochlorperazine on it. It's just a very popular drug. And again, anecdotally, I think people get a good response. It comes IV, IM, PO, and rectally. So you have a number of different ways to get this into a patient. If they aren't tolerating orals very well, you've got a plethora of options. Again, super common. Chlorpromazine or thorazine is not a popular choice. This was again one of those options that we pulled out of our back pocket when we ran out of prochlorperazine for a while. And I'll just give a little caveat here with why I'm talking about some of these weird alternatives. Nausea and vomiting medications seem to be one of the highest prone to drug shortages within the last 5 years. It seems like every once in a while, one of them gets completely out and we can't get it. And so what happens is every hospital or health system in the world or in the country tries to order as much of the other ones as they can. And so then they create shortages in those other pockets because all of a sudden the demand spiked for these other drugs. So occasionally you see these alternatives come back into play, but really we've been okay with prochlorperazine for a while, so I don't think chlorpromazine is getting a whole lot of use. Promethazine, yeah, still getting some use in some other areas. But anyway, chlorpromazine, I brought it up because it's similar to prochlorperazine. It is an antiemetic technically. It's also an antipsychotic, but its use is for irretractable hiccups. So if somebody's hiccuping, you can't get rid of it. You can give chlorpromazine. It's been shown to stop that. So, interestingly enough, if you ever come across that, that's one that you can use it for. Side effects are similar to what we talked about with Reglan. So these drugs, especially chlorpromazine, is actually used in some cases still as an antipsychotic for schizophrenia. It's an odd choice, but in patients who have tried a lot of other common options, they might be on this. But it is an antipsychotic, and prochlorperazine is heavily related to it. And so they all have this ability to cause extrapyramidal symptoms. TD stands for tardive dyskinesia, which we're going to get into a lot more detail on this during psych and what specifically that means. But tardive dyskinesia is a permanent movement disorder, and a lot of it has to do with kind of developing a permanent facial tic. Sometimes people flick their tongue weird. If you ever do some sort of a psych rotation and you talk to schizophrenic patients, you might see some, especially if they're older, they've been on some of the older treatments. It's not an uncommon thing to see somebody talk and they kind of like are sticking their tongue out weird at you continuously, like they're like licking the air. Tardive dyskinesia. Again, permanent, not good, very, very rare. EPS, extrapyramidal symptoms, much more common to see, but still not something you're going to expect with an antiemetic dose. You aren't going to expect to give somebody a compazine injection and see extrapyramidal symptoms. It's just probably not going to happen. But it's a good idea, especially if they're chart flags and you see, hey, they have an allergy to prochlorperatine in the past. The odds are it's probably some sort of a movement dystonia or something like that they got. Side effects, possibly hypotension, but hemodynamically should be pretty stable overall. I will give the side note here that for these types of movement disorders with antipsychotics, and again, we're going to come back to all this in psych and talk about it again in that context, but in the context of antiemetics, diphenhydramine and anticholinergic medications actually do work pretty well to prevent these types of symptoms. So let's say somebody's really nauseous and you want to give prochlorperatine because you think it'll probably help them, but they have a side effect. They said in the past they had some gait disturbance after. Give them a shot of Benadryl first. That's also an antiemetic, should be relatively benign. And then try prochlorperatine. That combination of prophylaxis with the Benadryl plus the compazine can actually mitigate that side effect pretty well. And again, we use that strategy in mental health a lot with anticholinergics. But once you get EPS, it's very hard to stop it by using anticholinergics. It's almost, as my ED providers would tell me, you can't. It doesn't work that way. You have to give it before you give it. So that's the only way it works. So just keep an eye on that reaction. Again, pretty unusual to see it with an antiemetic, but it's certainly possible. I don't even know why I keep droperidol on there. It's kind of like a tease. Droperidol doesn't really exist anymore. It used to exist, and it was a very popular antiemetic. It's short-acting form of a drug called Haldol or haloperidol, which is down here. Haloperidol was one of the original long-acting antipsychotic medications, and it's still used a little bit today. It's a very potent sedative, and it's also a very powerful antipsychotic that causes really bad EPS. So if you gave somebody a shot of haloperidol, you're probably going to get some EPS if you don't prophylax against it. It's very, very common with that medication. Droperidol, much less potent version, much less likely to cause the side effect. It's still possible, and much shorter acting, so it doesn't stick around as much. Still pretty sedating, but we can't get it. Now, someday I'm optimistic that droperidol is going to magically reappear on the market. I think one of the reasons why it disappeared is because people weren't using it all that much, and then people started using it for acute psych exacerbations. So when somebody was agitated, they would give them a really high dose of droperidol, and it would calm them down quickly. Whereas if you gave somebody a really high dose of haloperidol in that situation, which we also do, you've got like an 18-hour half-life to consider where the person's sedated. Where droperidol, you can redose them in a few hours if you need to. A little bit more control that way. But anyway, droperidol is a pretty decent antiemetic. Doesn't exist anymore. For now anyway. Might be back on the market, but who knows? It's been years. I think it went out when I was a resident in pharmacy, and when I was probably, when was that? 2012 maybe, when it was last available, or maybe 2013. And they kept saying, oh, it'll be another few months before we see it again, and here we are. And I don't think anyone talks about it anymore. Yeah. It was a shortage. Yeah, I don't know if it was a raw materials thing. Sometimes the compounds they use to synthesize the end product get out of stock for some reason, or their supplier stops making the raw materials, so they can't make the reaction to get the final product. That's a common source of drug shortages too. So I don't know exactly what happened, but yeah, originally it was a shortage, and they're going to make more of it, but we just haven't ever seen it. So again, it could come back. But.
Is it safe to say that when you say prophylaxis for the EPS, is that like work all the time? Is that
Not 100%, but it certainly gives your patient a much better chance than if you don't. Yeah, you could still see it, especially if you gave a drug like haloperidol. That's going to be much higher risk than like something like prochlorperatine. Very low risk to begin with. Haloperidol is an antiemetic. I've used it a handful of times, and the reason you have to be careful is because of the side effect profile is much higher risk with it. Also, it's got this super long half-life, so your patient's going to be knocked out for quite a while. I had a colleague of mine, fortunately I didn't do this, but a colleague of mine recommended giving haloperidol to somebody once, and the ED doc was furious because that person basically had to sit in the emergency department for like 10 hours in a bed because they were sedated. So just be a little bit careful with it because it is really sedating. They didn't have anyone to pick them up or drive them home or anything. No, EPS is short-lived, and if you kept giving the drug at regular intervals, it might appear permanent, but if you stop the drug, it should withdraw. Yeah. All right, we just talked about metoclopramide. So metoclopramide has some dopamine antagonism. It's also got serotonin blocking effects within the central nervous system, and it's got some cholinergic effects. So you'd think reading this, well, isn't this the perfect antiemetic? Well, I don't know. I think a lot of people would say this is maybe kind of a second-tier choice compared to prochlorperatine. It doesn't really have the potent effects you would get from the other drug. Now, is that clinically proven and evidence-based? No, it's more anecdotal. It is category B in pregnancy, so again, with this one and diphenhydramine, those are two drugs we like to use in pregnancy. Prochlorperatine in pregnancy is a little bit iffy. Some of the studies say that there might be some possible harm. It's a category C, which is, we'll get to that during what exactly that means. Basically, it means that they might have looked at animal models, but there's really no human evidence to support that it does anything pro or con with respect to the fetus. So category C in pregnancy is sort of we don't really have a recommendation. But this drug's category B, which means there's probably some good animal studies that show that it's not harmful for fetal development. And then diphenhydramine is also category B too. So those are your two more or less go-tos, and another drug we haven't gotten to yet. But as far as the dopamine receptor antagonists, one thing that I put here is warning with other D2 antagonists. Don't double up on them. So again, by themselves, metoclopramide, promethazine, prochlorperatine, very unlikely to cause EPS. If you gave a bunch of them together, much more likely to cause it. So when you're giving people antiemetics, just make sure not to double up on these. You can give metoclopramide, and like within the dosing interval, 6 hours later, give prochlorperatine. That's fine. Just don't give metoclopramide and 10 minutes later say, well, they aren't getting relief, I'm going to give prochlorperatine. That's a big no-no. We want to mix and match our categories and not double up on the dopamine antagonists. All right, other options within this category. I put olanzapine down here just as a footnote. Olanzapine is also known as Zyprexa, which is a newer generation antipsychotic medication. You'll notice there's kind of a trend here. Antipsychotics seem to have antiemetic effects. And olanzapine is a drug that actually was studied in some small groups of people where they've done smaller doses than what they do for a psychiatric emergency. So it comes as an IM form, which you can give somebody as a shot if they're having an acute psychiatric exacerbation. And if you give a smaller dose of that, it does have some antiemetic benefits as well. And they've actually done some studies to say that you can give the IM formulation intravenously to get even a faster response that way. And so we've actually seen this use a little bit increase in our emergency department. Even though it's kind of off-label and it's not technically recommended by the manufacturer, they still will do it. So I brought that up because I think it's getting more and more popular. And if you go into EM or any type of urgent care, you probably see it get used more frequently, especially Hennepin. They like to do that a lot. All right, serotonin receptor antagonists. So this is kind of the big drug category as far as the most popular, usually first-line choice. And the drug that is almost always used. I'm going to talk about there's multiple ones available, but ondansetron or Zofran is the drug in this choice, or in this category. It's on the next slide. But probably one of the most useful out there. The side effect profile is excellent. You don't have any EPS to worry about. In fact, there's almost no side effects associated with these whatsoever. So almost always first line. You can mix these drugs with a dopamine antagonist safely. There's no problem doing that. So again, if you give, so a lot of times what you'll see done in acute nausea is somebody gives a serotonin antagonist, they don't get a good response, then they'll go to their dopamine. Serotonin ones are usually considered the first line. And for any antiemetic regimen, if it's chemotherapy related, if it's acute, whatever it is, ondansetron or some sort of serotonin receptor antagonist is going to be a primary cornerstone of that regimen. They're just ubiquitous when it comes to antiemetic. So anyway, ondansetron is our preferred drug here. It's common, it's generic, it comes as a an IV product. It comes as a generic tablet. It comes as an orally dissolving tablet as well. The orally dissolving tablet can sometimes be kind of expensive still, even though it's generic. So it's not the cheapest generic option, but it's still much less expensive than the rest of these. The other three medications I'm not concerned you know for the exam. They're odd. They have very niche indications. All I want you to know is that ondansetron is a serotonin receptor antagonist. and then the rest of the stuff about serotonin receptor antagonists. Now, if you work in chemotherapy or something, you'll probably see some of these used to a certain degree. We see a bit of Kytril or granicitron used, and there's specific chemotherapy regimens that call for that. And again, it's very indication specific, very drug specific too. So the average patient who's got nausea is not going to get any of these other drugs. They have some differences, but again, that's all I'm going to talk about with them. Again, well tolerated. Maybe mild headache was probably the most common incidence of general common side effects. And then also, it can prolong the QTC interval, which if you're giving this acutely and in as needed intervals for patients' nausea, it's probably not going to affect anything at all. If you're giving it scheduled every 8 hours for a couple days, you might see the QTC rise up. But our rule of thumb, whenever we talk about QTC prolongation, is that it's all about how many agents are doing it, not whether one is doing it. Now, that's not an absolute rule, but I feel like in my practice and what you see in the literature, that's what you're going to get the biggest risk, because if you're stacking up QTC prolongers, that's your problem. So if your patient's already on amiodarone or dofetilide or some sort of antiarrhythmic, you might want to be careful with Zofran. But otherwise, for the most part, you don't have to do extra QTC monitoring because you gave somebody some PRN and Zofran. Just be careful. And you can always cross-reference their med list with a pharmacist or with a drug monograph database or something like that to see what else is prolonging QTC. All right. Glucocorticoids can work okay for as an antiemetic, and the mechanism, no one really knows why they do it, but they're especially dexamethasone is a cornerstone of chemotherapy-related regimens, and it's almost always considered to be the best glucocorticoid for antiemetic purposes. So for acute nausea and vomiting, you're probably going to use the other drugs we've talked about already, but you could try a glucocorticoid if somebody's not responding. Glucocorticoids are also generally okay, especially in small amounts in short term in pregnancy. So it could be an option for somebody. And when we keep bringing up pregnancy, we're going to talk about this more during the specific peripartum lectures. But when you get something called Gravidara. Oh, I can't remember the term. Shoot, I'm sounding like an idiot now. But it's a very powerful emesis response to pregnancy that basically you can't keep anything down. We've had to have patients on parenteral nutrition because of it before. This would be something that if you can try and avoid a situation like that with a drug like this, it's an option. But for most cases of acute nausea, this isn't going to be something you're going to use. And cannabinoids. Cannabinoids, this comes up every once in a while about where do you use these. They don't really have a great role in acute nausea and vomiting. There are some chemotherapy cycles that are for a chemo patient. I think you can get medical marijuana now using Minnesota's laws, and certainly in maybe other states you can get it with looser laws. But the two products that are cannabinoid related are Dronabinol and Nabilone. Dronabinol is essentially purified THC. It's a controlled 3 substance. So wrap your head around that for a second. Marijuana itself is a controlled one, but we have a drug that's purified THC in synthetic form that's C3. Anyway, regulations are kind of weird. That's all I'm going to say about that. Anyway, it was shown to be superior to placebo and possibly even superior to prochlorperatine, but inferior to metoclopramide in another study, which is interesting because there are studies out there that show that prochlorperatine is superior to metoclopramide. So which nausea drug is best? I don't know. Pick one. But these drugs are generally pretty expensive. They usually aren't covered by insurance, and they're very specific for certain indications. So a lot of times refractory chemo-related nausea and vomiting, a big use that I've seen these in, not quite as much now that the HIV drugs are so much better than they used to be, but there's a lot of appetite suppression and kind of wasting for our HIV patients before our drugs got better, so they used to use this quite a bit for that. But certainly for appetite stimulation, it seems to be a fairly effective medication. Yes?
So I thought I heard somewhere if you excessively take cannabis, that you can cause yourself a permanent nausea?
Yes.
So can that happen with these medications?
I suppose if you took a ton of it, you'd probably have to overdose intentionally on it, yeah. But yeah, that's something, we're going to talk about marijuana a little bit, and we'll talk about some of the strategies. We've actually seen in some of the states that have legalized it recreationally have seen a big uptick in that specific complication. Basically, you're just overusing your receptors is what I think is happening. Nabilone or Cesamet is super rare. I've never seen it used. I'm not going to spend any time on it. It's a different specific CD1 cannabinoid synthetic, but it's really expensive and, again, very unusual to see this used. It'd be for a very specific type of cancer patient that hasn't responded to anything else, I think. Benzodiazepines, touched on these a bit during when we talked about kind of like antispasmodics and muscle relaxants, but benzos are not traditional antiemetics. They're traditionally used for a couple things, sleep and anxiety, so we're going to come back to them during psych in much more detail. But Lorazepam or Ativan is a drug that's been used in a lot of different applications related to nausea, and it seems to be quite effective. I've seen a lot of people in the emergency department who are nauseous and have anxiety on top of it because they're sick. They feel a little bit anxious about being in the hospital. Ativan's a great drug for that. Assuming your patient isn't, seeking the medication or isn't, addicted to something else, it can be a really useful agent to calm somebody down and suppress their nausea at the same time. It can also help with some of the movement disorders associated with things like metoclopramide. This is supposed to say prochlorperatine, not dexamethasone. Sorry, dexamethasone doesn't cause akathisia. And it is sedating, so it's going to be additionally sedating. A lot of these medications are sedating already, so you're adding something on top of it. But it's a useful tool that is a pretty effective antiemetic, actually, even though that's not technically what it's designed to be used for. Okay, so summary. First line, I think, really depends on the situation. Generally speaking, ondansetron is going to be your first-line agent in pretty much any application that involves nausea. It's effective for chronic. It's effective for acute. It's going to be a good drug to be your go-to for nausea. Your backup classes are going to be your D2s. So whether you go to prochlorperatine or metoclopramide depends on your patient. Generally, you're probably going to pick prochlorperatine, I would think. It's a little bit more potent. Studies, I would say, literature would show that prochlorperatine is likely slightly more effective than metoclopramide. I can't hang my hat on that, but that's my opinion. Metoclopramide would be the preferred agent, though, in a pregnant patient because it's category B. It's much more well studied. Ondansetron has some issues with pregnancy, and there's some interesting evidence and studies out there. I'm not going to say it can't be used because it certainly can, but I don't want to get into that right now. We'll go through the evidence during the peripartum lectures. It is kind of an interesting topic of discussion, but generally speaking, ondansetron, prochlorperatine / metoclopramide, and then you move down the line. Maybe you try an anticholinergic after that. And after you get to that point, it's a bit of, you're wading out into the weeds, into no man's land. And you can consider things like antipsychotics, maybe like olanzapine, or even haloperidol at that point, but those, of course, have risks associated with them. So no perfect option once you get past those first choices. Okay, so here's a quick little case. We've got a patient named BK. She's a 23-year-old female who presents to your emergency department for acute nausea and vomiting secondary to a migraine headache. You order ondansetron and prochlorperatine. She reports some relief, but your RN reports that she just had another episode of emesis. So what other options are available, and what else might you like to know or consider in this case? So I heard metoclopramide. Any discussion on that option?
You couldn't give it at the same time as
Right. Right, exactly. So you'd want to know what about this?
When I was last
Yeah. So what's the time interval between the two doses? So yeah. Did she get relief for 4 or 5 hours? And yeah, you're probably good to go. If it just happened within an hour, then you probably don't want to repeat a dopamine antagonist. So let's assume metoclopramide's ruled out. What are some other options we could try? Is she pregnant? I'll say she's not pregnant. Anticholinergics, diphenhydramine. Steroids, right? You could try dexamethasone. Again, a little bit of an oddball choice and not necessarily an intuitive one, but certainly effective in a number of, especially in chemotherapy-induced nausea and vomiting, but no reason why you couldn't try it in an acute patient who's not responding to their choices. And then your benzodiazepine, Lorazepam, would be the other two to keep in the back of your mind. So between those sort of 5 classes, if you think about it, so you've got your ondansetron or your serotonin antagonist, you've got your D2 antagonist, your metoclopramide and prochlorperatine. So those are 2 major ones you're going to use. And then you've got anticholinergics, got steroids, and then benzodiazepines. And beyond that, yeah, it gets messy, but those are kind of the tiers you would go down and choices you would look into. We're going to talk about migraine, and actually Antiemetics have a really good track record of stopping migraines too, so you kind of get a double bang for your buck there. But it's not something we'll go into too much detail at this point. But. All right.